You've all been attending and not getting any CME credits. So I've got the honor of introducing Dr. Tara D'Ignazio. Dr. D'Ignazio is from McGill University. She completed her medical school at the University of Montreal in 2024, and she's gone on over the last 2 years to do an interventional echocardiography fellowship at McGill University. She's very much interested in the education of medical trainees. She served as the co-chair of the resuscitation track of the trainee program planning committee for the Canadian Cardiovascular Society in 2021. And in 2022, she was involved in the cardiology track. And in 2023 and 24, she served as the co-chair of the whole trainee program planning committee for the Canadian Cardiovascular Society. So she's going to talk to us today about mitral TEER for primary mitral regurgitation, the evidence, evolution, and technical challenges. So thanks a lot.
Thank you so much for the introduction, Dr. Burwash. It's my pleasure to be here to speak to you today. I'm Tara. Today I'm going to be talking to you about mitral transcatheter edge-to-edge repair, or as many of you know it, MitraClip, for primary mitral regurgitation. So we're going to talk about evidence, evolution, and technical challenges, as Dr. Burwash mentioned. It's an interactive presentation, so I'm happy if you participate. I know it's early in the morning. And this is a presentation that I made kind of based on my questionings from my fellowship at the center where I trained at the McGill University Health Center. We do a lot of MitraClip. I say MitraClip because for now they don't have Pascal yet, and increasingly for primary cases of mitral regurgitation. So I really wanted to delve into the current evidence and the landscape that's currently changing around this pathology. So for conflicts of interest, it's pretty simple. I don't have any. Here's the presentation outline. So I'm going to start with a preface on primary mitral valve regurgitation. Then we're going to go through with pictures a step-by-step guide of M-TEER procedure, so a MitraClip procedure. Then we're going to discuss current evidence for M-TEER and primary MR and how that led to the elaboration of current guidelines. We're then going to get into some anatomical considerations for pre-procedural planning. We're going to go through an interactive case, and then we're going to discuss the very exciting future directions for M-TEER in primary MR, because there's a lot that's going to be coming out. So primary mitral regurgitation is caused by intrinsic abnormalities in the mitral valve leaflets or supporting structures. So it can be degenerative changes in the leaflets, myxomatous infiltration, calcification of the annulus, or damage to the chordae tendineae or papillary muscles. Most commonly in developed countries, it's going to be caused by Carpentier-2. So that's going to be our mitral valve prolapse, and mitral regurgitation that's caused by increased valve mobility. And the patients who have mitral regurgitation are around 10% in patients over 75, which makes it the most common valvulopathy. And these patients face a high burden of heart failure, dyspnea, atrial fibrillation due to atrial dilatation, pulmonary hypertension, and have increased mortality compared to patients who don't have mitral regurgitation. So it's a big issue, and increasingly so as our population ages. We need to develop more innovative ways to address this issue. So now we're going to go through a step-by-step guide of an M-TEER procedure, which is going to make it kind of more intuitive to understand what the anatomical considerations are later. So for those who have never seen it, a mitral transcatheter edge-to-edge repair is a minimally invasive catheter-based procedure to treat moderate to severe mitral regurgitation without cardiac surgery. So typically we would treat in the past mitral valve regurgitation with a sternotomy and with a mitral valve repair or replacement, but this procedure implies well, I say only a venous access, a transeptal puncture, and then deploying a clip within a commissure. So it's the equivalent to the surgical Alfieri stitch. So it closes up usually the middle commissure, and it creates two orifices on the side with the goal of reducing mitral regurgitation. So currently in North America, there are two models, which are the MitraClip by Abbott and the Pascal by Edwards Lifesciences. I'm not showing anything new to people who are echocardiographers. I put these slides in for people who maybe aren't as familiar with 3D imaging and the imaging that we do, particularly intraprocedurally. So This is the mitral valve anatomy. So the mitral valve has two leaflets, an anterior and a posterior. To orient yourself in the anterior posterior axis, it's quite easy because the aortic valve, we always place it at 12 o'clock at noon, and the leaflet adjacent to the anterior adjacent to the aorta is always the anterior leaflet because the aorta is an anterior structure. And here we have the three commissures. The one that's lateral is the one that's adjacent to the left atrial appendage. So that's A1, P1. Then we have A2, P2, which is central, and A3, P3, which is going to be adjacent to the interventricular septum. And putting it all together on 3D, that's what that looks like. So we have our mitral valve, our aortic valve, we have our left atrial appendage to the left. So we know that this is the A1, P1 commissure. It's the lateral commissure, the central commissure, and the medial commissure. So you're going to see clips like this throughout the presentation, and that's what that represents. Another view that's very important when we're guiding and also when we're assessing the mitral valve is the bicommissural X-plane scanning. So bicom view allows us to see the valve from the side and orient from the medial to the lateral commissures. So in these clips, it's easy. You see that you have the left atrial appendage here. So you know that when the X-plane line moves towards the left atrial appendage, you're going lateral, you're going towards the A1P1 commissure. When it's central, you're going to see that it's the A2P2 commissure that's shown on the biplane. So this is a three-chamber view, which is the equivalent of a parasternal long axis. And then as you move the X-plane line away from the left atrial appendage, you're going to be assessing your medial commissure. So this allows us to go through really commissure by commissure to assess mitral valve pathology and to assess where the mitral regurgitation is most severe and where the point of maximum pathology is. And we're going to see that it's also a very important view when we're guiding intraprocedurally in order to be able to align our clip both in the lateral, like the medial to lateral axis, but also in the anterior to posterior axis when we're on a biplane. So this is the anterior leaflet, this is the posterior leaflet, this is the lateral side, this is the medial side. So between the both, we're able to really orient the clip laterally, medially, anteriorly, posteriorly. So the first step, and not the least, in the procedure after establishing a venous axis is we're going to bring up the guide through the femoral vein into the inferior vena cava, which is then going to come into the right atrium, and we're going to start to attempt a transeptal puncture. So a transeptal puncture is very important because it's going to dictate kind of the steerability of the operator. So what we can do as echocardiographers is help the interventionalist achieve a punction that's as inferior and posterior as possible. So in order to do that, we're going to orient again in biplane. So we're going to take a bicaval view, which is at 95 to 110 degrees, where here is the right atrium. This is the superior vena cava. This is the inferior vena cava, and we're going to want to be as inferior as possible. And we're also going to orient in a short axis view around 45 to 50 degrees with the aorta being here. So remember, aorta is anterior. This is our anterior axis. This is our posterior axis. And we're going to want to go as far posterior and as far inferior as we can. The other thing that's important and that we can help with is making sure that we're in the thin portion of the septum, so in the fossa ovalis. If ever we're not sure, we can use 3D imaging to confirm that we're in the thin portion, because this reduces procedural complications such as hematoma and tamponade. So that's it. Once the position is confirmed, we're going to say we're in the thin part of the septum, we're where we think we should be. The septum will be dilated and the delivery catheter is going to be advanced through the septum. Before we do that though, we want to measure our atrial septal height. So we're going to want to measure the distance between the mitral valve and the tip of our catheter to make sure we have at least 35, ideally 40 millimeters, because this is going to make it easier to steer the catheter once it's in the LA for the interventional cardiologist. So this is our medial commissure, this is our A2P2 commissure, this is our lateral commissure. So as you can see, if we punctured lower, yeah. Oh, how do I point? Oh, thank you so much. Thank you. So you see my needle tip is here, and we're measuring the atrial septal height. It's still not working. Okay, now I'm on it. Okay, sorry for that. So we're going to measure our atrial septal height between the mitral valve annulus and the tip of the needle. And the reason for that is that if we puncture too low, we're obviously not going to be able to flip the catheter and have good maneuverability or steerability within the left atrium, particularly for those medial commissures. It's going to be very difficult. So having a good transeptal puncture is very helpful for the success of these procedures. And then after that, we're going to kind of move the needle through, move the dilator through, and then start bringing the delivery sheath into position. So that's what that looks like. So here we're advancing our catheter. After we've dilated the interatrial septum, we're satisfied with our height. We think we're going to have good maneuverability. So again, orienting in those two planes. And we can also look at it in a third dimension. So we see that we're coming from the inferior vena cava through the septum. And then we see that we have to start turning downwards towards this structure here, which is the mitral valve. We want to make sure that that catheter is not hitting the posterior part of the left atrium. We want to make sure that we're not causing trauma with the catheter. So that's something that we can also help with during the procedure. The next part is going to be to steer and straddle the correct commissure and to be well aligned in those two axes. So again, lateral, because we see the left atrial appendage and medial, and anterior and posterior. So depending on where our leaflet pathology is, depending which commissure is involved, we're going to want to be right on top of that commissure, and we can use X-plane and color to make sure that we're at the right place. Before we advance the catheter with the delivery system, we want to make sure that the clip is functional. So we're going to unsheath the clip and we're going to test the grippers. So one of the new functions of the new clips is that we can test each gripper individually, which allows for individual leaflet grasping. So we want to make sure that the clip is functional before we put it through the valve. So we test it, and then we're going to use this bicommissural biplane view in bicom and three-chamber view to orient the clip. So here we see that we're straddling kind of the medial part of A2P2. And here we can see that we're maybe a little bit too anterior, and we can, tell the interventionalist maybe to move their clip a little bit more posterior to be centered before we close the clip and ultimately go through the valve. So we always go into the valve with the leaflets closed. So this is another clip for orientation. So we mentioned this is the lateral axis, this is the medial axis. You want to be right where the pathology is, because that's going to be where we're going to have the best chance of procedural success. Anterior, posterior orientation. And then another part of orientation that's really important is we want to make sure that we're really in line, we're really perpendicular to the commissure that we want to address. So for that, we use 3D imaging. So this is a 3D reconstruction of the mitral valve, like I showed at the beginning of the presentation. So aortic valve, anterior leaflet, posterior leaflet, and we see that the clip is nice and aligned with the commissure. It's nice and perpendicular. We wouldn't want to clip. So you see that it's well aligned with the center. We wouldn't want a clip that would be tilted to the side or too horizontal. We really want to make sure that it's well aligned with the commissure. This is an A2P2 clip. If it had been A1P1, it would be more like this. A3P3 more like this, etc. So it's important to check orientation before we go into the valve. So this is just another picture that demonstrates the clip orientation in 3D. The next step is going to be grasping. So like I say, we're going to descend into the valve with our leaflets closed, and then we're going to open the leaflets and we're going to start pulling back until there's interaction with both the anterior and posterior leaflets. So let's see if I can get my mouse back. So here we see that there's interaction with the anterior and posterior leaflets, and that's when we're going to drop the grippers. and we make sure that there's no interaction with subvalvular structures. So you can understand that in order for us to clip successfully, there has to be enough leaflet length to be able to do that. If we have very short, very tethered leaflets, it's going to be very hard to accomplish this, and especially also if there's calcification that extends into the leaflets. So that's something to consider as well, which we'll get into when we discuss pre-procedural planning. And then finally, clip deployment. So then we close the grippers, and now the clip is closed. We see that it's well positioned relative to the pathology. We want to make sure that it's stable. So we want to make sure that we have good bridging on 3D views. So we're going to want to make sure that, you know, both the anterior and posterior leaflets are well grasped and that the clip is stable, and we're not going to have single leaflet detachment. And at this point, we're also going to assess for residual mitral regurgitation. So we're going to check pulmonary veins, see if there is a change between the beginning and the end of the procedure. And we're also going to check our gradient. So we want to make sure that we haven't traded mitral regurgitation for mitral stenosis. So if we're satisfied with the residual mitral regurgitation, then we'll release the clip if we're sure that it's stable and there's a good bridging. If there's a lot of residual mitral regurgitation, well, then we'll look at how much gradient there is and whether there's space for a second clip without increasing the gradient too much and diminishing the residual orifice too much. Another option is to, if the clip is not released, to reopen the grippers and try to optimize positioning. So we could try to reposition the clip, or we can potentially consider adding a second clip. So here the leaflets are closed. We're checking our bridging. And so now that you've seen the procedure, it becomes a lot more intuitive to understand what elements might make clipping difficult or even futile. So which anatomies are not amenable to this procedure and what might make things technically challenging. So if people want to offer answers, I'd be happy to take them. I know I'm not teaching anything necessarily to echocardiographers, but maybe to other people in the room. So what might make things difficult? If not, I can just go through them. Yeah, so leaflet tethering, that's a good point. Yeah, that's true. So I'll go through them. So as we mentioned, calcified leaflets, it's going to be difficult to grasp them. Stenotic or rheumatic valves, because as you see, we do close part of the orifice and we do increase gradients. It's estimated that we decrease mitral valve area by around 40 to 50% when we do this procedure. So gradients will go up with the clip. We just have to make sure that they're acceptable. So we should not be addressing valves that are rheumatic or stenotic. Small posterior leaflets, so not having enough leaflet to grasp. Very tethered leaflets, as you correctly mentioned, which is something we see more in functional mitral regurgitation. Not necessarily a formal contraindication, but if we have a low height to the posterior rim of the fossa vallis, if we have a low atrial septal height, it is going to be harder to achieve the same steerability within the left atrium. Large gaps between leaflets, so when we're talking about partial flail segments, if there's a large distance between them, it's going to be hard to grasp them with the current clips that we have. And finally, anatomy that simply cannot be fixed with a clip. So Barlow's disease, if you have prolapse of a complete posterior leaflet, restriction of the posterior leaflet, if you have endocarditis, cleft, or leaflet perforation, these are not anatomies that are going to be amenable to a clip and will not be helped by a clip. So are relatively counterindicated. So now we're going to discuss the current evidence for mitral transcatheter edge-to-edge repair and primary mitral regurgitation. So once again, this is primary MR. I'm not going to be discussing MITRA-FR and COAP because those concern secondary. And it's quite simple. For now, there's only one head-to-head randomized controlled trial that included these primary mitral regurgitation patients, and that's Everest 2. So this is a 2011 trial that was published in the New England Journal of Medicine that included 279 patients with moderate to severe or severe mitral regurgitation, and they were randomly assigned to either percutaneous repair, so MitraClip, or mitral valve surgery. The primary composite endpoint was freedom from death, surgery for mitral valve dysfunction, or from 3 to 4 plus mitral regurgitation at 12 months. And the primary safety endpoint was composite of major adverse events at 30 days. So they took symptomatic patients who had to have an ejection fraction greater than 25% and an LV end systolic diameter less than 55. They also included asymptomatic patients who had to have an EF between 25 and 60%, which is low for patients with severe MR, dilated but not too dilated end systolic diameter of 40 to 55 millimeters, and either new atrial fibrillation or pulmonary hypertension. So you had to have one of these if you were asymptomatic. And then another important point of this this study is that these patients had to be candidates for both M-TEER and mitral valve repair or replacement surgery. So these patients had to be candidates for surgery. They were not prohibitive surgical risk patients. So in terms of the patient demographics, they were adults with a mean age of around 67 years of age. A third were female. And interestingly, the majority actually had degenerative or primary mitral regurgitation. So only 27% were functional cases, 63% were degenerative cases. There was a high prevalence of heart failure symptoms in these patients, which is to be expected in a cohort of mitral regurgitation patients. They had a moderate burden of cardiovascular comorbidities like CAD, atrial fibrillation, and hypertension, and the average ejection fraction was around 60%. So these were patients with relatively normal left ventricular function. And these were the trial results. So they had a composite of freedom from death, from surgery for mitral valve dysfunction, and from 3 to 4 plus mitral regurgitation. So this was encountered in 55% of the MitraClip group and 73% of the surgery group. So statistically different in favor of surgery. And the big driver of this difference in the composite wasn't difference in death, which was pretty much similar between the two groups and not statistically different. And it wasn't residual 3 to 4 plus mitral regurgitation. It was really driven by the difference in need for surgery for mitral valve dysfunction, which occurred in 20% of the patients who had undergone a MitraClip. So 20% of those patients who had a MitraClip ended up needing a valve repair or replacement after their MitraClip. In terms of the safety results, which they also presented, so any major adverse events, which are defined below, is actually in favor of MitraClip. But when you go into the really granular data of why that was, it wasn't a difference in death or MI or stroke. It was really driven by the surgery group having more patients that required mechanical ventilation for more than 48 hours, and especially by transfusion of greater than 2 units of blood in the surgery group. When they did an assessment of how the patients felt compared to their baseline, overwhelmingly, the patients who had undergone MitraClip felt better. So they had a better physical component at 30 days, and at 12 months, they had a better mental component at 30 days and at 12 months. So even though maybe, as we can see, quite a few of these patients actually did still have moderate to severe or severe MR after their procedure, most of them did feel better. So there was a clinically relevant outcome, despite that there was still quite a bit of MR and in a subgroup of patients, and up 20% had to undergo surgery ultimately. So this is their subgroup analysis. So for all patients using their composite outcome, surgery was better than percutaneous repair for all patients. This was especially true for patients under 70 years of age, and especially true for the degenerative mitral regurgitation cohort, which is what we're talking about today. So what the Everest 2 trial told us is that M-TEER is a safe, possibly safer alternative to mitral valve surgery at that time. It improves NYHA class, quality of life, LVEF, LV end diastolic measures, and NYHA class, even if mitral regurgitation persists. Ultimately, 20 to 21% of patients having had MitraClip needed mitral valve surgery, and ultimately, mitral regurgitation was handled more definitively by mitral valve surgery than by transcatheter edge-to-edge repair. So that was with the Abbott G3 clip. Since then, the G4 has come out, which has more sizes, so it allows for the treatment of more complex anatomies. And allowed for a single leaflet grasping. So they did this single-arm, multi-center, post-market observational study for which 43% of their cohorts were primary mitral regurgitation patients. So at 1 year, for patients with primary mitral regurgitation, we can see that at 30 days and 1 year, the vast majority, so 88.8%, had either mild or trace mitral regurgitation. And this was true even when we paired the subjects. So 88.6 at 1 year had either mild or trace mitral regurgitation, which is a fantastic result compared to what we saw in Everest. And then they even went further. So they had used certain anatomic exclusion criteria in Everest, and they expanded them. They really wanted to see what would happen if we started tackling more complex anatomies. So mitral regurgitation that had MR that was outside of A2P2, had more than one significant jet, had an extremely wide MR jet, small mitral valve area, mitral annular leaflet calcification, minimal coaptation length, presence of severe leaflet degeneration or flail glaps, widths greater than 15, cleft, bileaflet flail or prolapse. So they said even in this cohort of complex patients who had at least one of these anatomically complex features, at 1 year, they achieved MR less than or equal to 1 in 90% of their patients. And when they paired their analysis in 90% of these patients, so these results were fantastic. Then came the STS registry, which was a registry of all comers with primary MR and secondary MR, but I'll speak about the primary MR cases post G4 MitraClip. So they looked at real life data, not kind of the industry funded, like very controlled deployment of the MitraClip, but how it was being used in real life. And these patients were older. So these were 82-year-old patients who had an average STS score around 4.6%. So this was considered an intermediate surgical risk, but not prohibitive surgical risk. And in their initial publication, they said that 88.9% of patients achieved optimal results at 30 days, which they defined as MR less than or equal to 2+, no severe mitral stenosis, and a mean gradient less than 10. So still, you know, they were considering moderate MR a win and a mitral gradient of less than 10 as a win. So then, okay, about 89% of patients meet that criteria. But in another study that kind of looked into a different definition of optimal. So they used the group that had the best clinical outcomes. So the best clinical outcomes in these patients was seen in patients who had mild or less residual MR and a gradient of less than 5. And according to the registry data, only 52.4% met this definition. So 36.6% of patients were discharged with either moderate MR or moderate mitral stenosis, and 11% were discharged with severe mitral regurgitation or severe mitral stenosis. And there are observational studies that looked at whether that was relevant. Is it does it make a difference if a patient goes home with moderate MR or gradient more than 5? And it does. They had increased mortality compared to people who had a successful clip as defined by these criteria. So there is a clinical implication, but probably still clinically meaningful to put a MitraClip and reduce their symptoms. So that leads us to where our current guidelines for mitral transcatheter edge-to-edge repair lie. So these are the American ACC/AHA guidelines from 2020, who reserve M-TEER in severely symptomatic patients defined as NYHA class 3 or 4 with primary severe MR and high prohibitive surgical risk. TEER is reasonable if mitral valve anatomy is favorable for the repair procedure and patient life expectancy is at least 1 year. So they said you can do a clip, but it has to be in a patient who couldn't have undergone surgery otherwise and has at least 1 year to live and has an anatomy that's favorable for the procedure. They also discuss pre-procedural risk factors for these patients. So consider the implications of multi-valve disease, valve morphology, which we're going to get into a little bit more, and clinically to be wary of patients with severe COPD, home oxygen, pulmonary hypertension, hepatic dysfunction, and frailty. Which should always be assessed before we recommend patients for these procedures, and to be wary of patients with STS scores greater than 15, life expectancy less than 1 year, and poor candidates for rehabilitation. We have more recent guidelines that come from the ESC, EACTS. So in 2025, they published new valve guidelines. So in patients with severe primary mitral regurgitation and symptoms, because we shouldn't be treating asymptomatic patients, who are high surgical risk, according to the heart team, and who are anatomically suitable for a clip, TEER is given a class 2A recommendation for them. So I'll just mention that these algorithms are very different from the treatment of secondary MR, where really GDMT is the first cornerstone of treatment. These patients don't have an indication for pharmacological treatment unless they have heart failure. Of course, their blood pressure should be managed, but for example, in a patient with flail or with an organic mitral valve disease, like you're not going to have the same effect on the MR by treating LV remodeling, because that's fundamentally not the pathology here. Anatomical exclusion criteria come from the Everest trial. So I showed you the procedure before, and now that you've kind of seen how it works, you can understand why these anatomies would be more difficult. So you want to make sure that you have a coaptation length, so where the leaflets are touching here, about at least 2 millimeters to ensure grasping. You want a coaptation depth of less than 11 millimeters, because coaptation depth is actually a surrogate for leaflet tethering and LV remodeling. So this is more true in secondary MR, but if your leaflets are very tethered apart, it's going to be very difficult to go grasp them thereafter with a clip. And for the anatomies that concern us in primary MR, so we want to make sure that our flail gap, so I just want to make sure that here we go. So the gap between these two leaflets should ideally be less than 10 millimeters. Otherwise, it's going to be difficult to grasp both leaflets. And our flail width should ideally be less than 15 millimeters. So when we look at how much of a flail segment there is, we can't have these huge posterior leaflets that are greater than 15 millimeters, because we won't be able to address those anatomies with a clip. So these are examples of non-ideal pathology. So this is a short posterior leaflet, so you simply won't have enough leaflet length to go grasp that. Calcification of the annulus that extends into the posterior leaflet. So here we see that there's a lot of calcification and it extends into the leaflet. So it's going to be very hard to grasp at this level. If not, as we mentioned, stenotic valves. So valves who have very small MVAs are going to be most at risk of increasing their gradient. So in studies that were done, the most important predictive factor of high gradient post mitra clip or M-TEER was actually the mitral valve area by 3D MPR. So that's the gold standard in 2026. So we really have to take a 3D image, really aligned well in all of the axes, and make sure that we're at the leaflet tip, and make sure that we have a mitral valve area ideally over 4 before we consider putting a clip. So this is the M-TEER pre-procedural checklist. In summary, you want to make sure that you have a valve that will tolerate a clip in terms of its gradients, because you don't want to trade MR for mitral stenosis. So mitral valve area greater than 4, mean gradient less than 4. If you have a flail segment in degenerative MR, you want to make sure that that flail gap is less than 10 millimeters, your flail width is less than 15 millimeters. You want to make sure you have adequate leaflet coaptation, so coaptation gap less than 10 to 12, coaptation length greater than 2, coaptation depth less than 10 to 11, and you want to make sure that your leaflets are adequate and optimal for grasping. So you want to make sure that you have at least 10 millimeters of that posterior leaflet, minimal calcifications at the grasp site, no cleft, dramatic restriction, perforation, endocarditis. You want to make sure that your leaflets are going to be good for grasping. So what should be included in a primary mitral regurgitation report? A lot of this information you can get from transthoracic echo as well. You're going to want to discuss mechanism of mitral regurgitation, including Carpentier classification, of course, severity of mitral regurgitation with quantitative measures such as ERO, 3D ERO, vena contracta, and interrogation of pulmonary veins. You're going to want to discuss and mention the presence of clefts or indentations, particularly if they're close to the grasping site. As mentioned, you're going to want to mention your mitral valve area by 3D M-TEER and your mitral valve gradient and at what heart rate. You're going to want to mention your posterior leaflet length and whether the leaflet is calcified. You can be very precise for the assessment of this in 3D, so you can really go exactly where the pathology is and where you think you're going to grasp and assess the posterior leaflet length there and its quality at that point. I'll discuss it later in the case. You want to look at atrial septal height, which is not a counterindication, but is definitely going to determine what kind of steerability you're going to have within the left atrium once you're doing the procedure. And like with any pre-procedural report, you're going to want to include LV systolic function, RV dimensions, systolic function, and tricuspid regurgitation, which are important for prognostication as well. So feasibility of MitraClip has changed a lot in the last years, and this is because the clips have gotten better and the operators have become better as well. So we know that patients who do not meet Everest criteria have higher rates of reintervention. We know that anatomic complexity is associated with lower rates of optimal mitral regurgitation reduction after M-TEER, and residual MR greater than or equal to moderate is strongly linked to worse clinical outcomes. But we also know that the results are also highly dependent on the center expertise and operator expertise. So high volume centers will have better outcomes than lower volume centers. And so patients with more complex anatomies we should consider referring them towards centers that do a lot of these clips. So as discussed, non-complex, ideal would be an A2P2 pathology, no calcifications, an ideal mitral valve area, posterior leaflet length greater than 10, tenting height is low, flail gap is less than 10, flail width is less than 15. Complex but suitable at this point with the new clips would be isolated commissural lesions, so A1 or P1 and A3, P3, annular calcification without leaflet involvement. These kind of limit mitral valve areas between 3.5 and 4, a little bit shorter leaflet length, asymmetrical tethering, flail width more than 15, flail gap more than 10, or 2 jets from leaflet indentations. The very challenging would be commissural jets, multiple jets, fibrotic leaflets, lower mitral valve areas, shorter posterior leaflets, Barlow's disease, cleft, and patients who have undergone failed surgical annuloplasty. And the ones that we should just not do are those who have concentric MAC with stenosis, as discussed, very small mitral valve areas, significant mitral valve stenosis, so that mean gradient more than 5, very short posterior leaflet, calcified in the grasping zone, deep clefts, leaflet perforations, rheumatic mitral stenosis, and I'll add endocarditis. So those are cases that we should not be doing by clip, just in terms of suitability. So now we're going to discuss, we're going to apply this to a real life case. So there are going to be some questions that are interactive. So this was the case of an 86-year-old woman who was living independently and autonomous, who was transferred per hospitalization for heart failure from an outside center. She was known for hypertension, dyslipidemia, glaucoma, breast and bladder cancer, and had had chest radiation. She was known for a heart failure with preserved ejection fraction, AFib, CHAS3 on a DOAC. She was treated with beta blockers. At this point, she was on IV Lasix, apixaban, amlodipine, and candesartan. And she was transferred for severe mitral regurgitation. We didn't have the report, but we had the pictures. We'll assume for the sake of this that the patient was turned down surgically because of her relative frailty and the fact that she had had prior radiation. So cardiac surgery didn't want to do a mitral valve repair, so we were asked to do a clip at this point, but we had to decide whether her anatomy was suitable. So this is our first clip. I didn't put color. If anyone wants to volunteer what they think the pathology is and where the jet might be going, I'd be very happy. But if it's early and you'd like me to keep talking, that's okay as well. Perfect. And where do you think it's going to go? Fantastic. Agreed. So posterior leaflet flail, and we measured a 4 mm flail gap and a 12 mm posterior leaflet. I can't comment on which commissure it'll be yet. I had to do more pictures for that. So then we evaluated the posterior leaflet on 3D. So this is our 3D picture, and we see that that little flail segment is popping in and out of the screen, and it looks like it's in the medial portion of A2P2. And if you see, we've put our crosshair lines really exactly where that flail segment is, and that allows us to go assess the quality and the length of the posterior leaflet exactly where we're going to grasp. So in more complex anatomies, if you have clefts or calcifications, you're really going to want to make sure that you're aligned exactly with where the pathology is and exactly where you want to grasp. So adequate tissue, not too calcified, as mentioned. The posterior leaflet length is 12 mm. We already assessed the flail gap. Then I did a BICOM X-plane, so starting more lateral. So we see that there's a little probably torn cord flopping in the left atrium. So A1P1 with the color now, A2P2 with the color, and then A3P3 with the color. So based on that, which one, like where would you locate the jets? Which one looked the worst, in fact? So it looks like it, you see the flail, I don't know if you see my, we can see definitely more of that flailing segment as we're in the kind of P2, P3 zone. So the medial part of A2, P2, and that's also not surprisingly where we see the color. So a fun challenge is always to look at where you think the pathology is and where you think the jet is going to go. And so here we see a very antero medially directed jet. So. Okay, so a severe anteromedially directed mitral regurgitation jet from the medial portion of A2P2. That's what it looks like. So it doesn't look like a huge flail gap. It looks like a very specific segment. And then we did more assessments. So we did a 3D. So in 3D, you can also assess where the jet is going. So we see that it's throwing itself anteriorly and medially based on this 3D. If ever you want to confirm, you can always put it in true view and kind of tilt it or look from the other side. Those are good ways to assess where your jet is originating from. We measured an ERO of 0.82 and a regurgitant volume of 106, which is definitely compatible with severe mitral regurgitation. There was also reversal in the right-sided pulmonary veins. Mitral valve area by 3D, we had mitral valve area of 4.08 by 3D M-TEER at the leaflet tip and a diastolic mean gradient of 2. So this is our summary. So it's a flail medial P2 scallop. So flail gap of 4 mm isolated to P2 with not a too large width, resulting in severe regurgitation directed anteromedially, Carpentier 2, presence of systolic flow reversals in right-sided pulmonary veins, ERO 0.82, regurgitant volume I wrote 28, but it's 128, posterior leaflet length is 12, mitral valve area is 4.08, and the atrial septal height to the posterior rim of the fossa ovalis was 32.7 millimeters. So based just on the echographic criteria, are there any counterindications to mitral clip or M-TEER for this patient? So I'll put this kind of simplified table, and then you can decide kind of where the patient falls. So favorable is going to be option A, less favorable is going to be option B, and contraindicated is going to be option C on the next slide. And then I'll ask you to raise hands. So I think I'll leave you a few more seconds to decide where this patient might be. All right, so who votes for A? Who votes for B? Who votes for C? So actually this patient didn't have any any major concerns because it was mainly an A2 pathology. Her flail width was not so large. Her flail gap was less than 10. Her leaflets weren't calcified. Her mitral valve area was adequate, and her posterior leaflet length was around 10. So with careful assessment, there weren't any counterindications anatomically to performing this clip. Based on the information presented, what might be difficult technically, however, even though it's not a counterindication? Does anyone want to volunteer? Correct. Fantastic. So the septal height was quite short, so only 31 millimeters, which we were able to overcome with a steerable sheath. And what's even worse is that it was a medial pathology. So if it were lateral, then, if we punctured a little bit lower, then we could get some steerability and go lateral. But when it's more medial, these short atrial septal heights become less forgiving. So we did our transseptal puncture, and then we were steering towards A2P2, the medial portion. Oops. We oriented our clip in 3D. And this was our result after our first clip. So we can see that there's quite a bit of residual mitral regurgitation, especially on this medial side of the clip, so the side opposite to the left atrial appendage, but our diastolic mean gradient was only 2. So what we decided to do was continue assessing. So this is a 3D of the residual mitral regurgitation with the clip. So we see once again that it's very medial to that clip. And then, oops, we measured an ERO for what that's worth post-clip, and it gave us around 0.2. And so we decided to put in a second clip, even more medially. So we really needed whatever atrial septal height we had, because you can see that the angle here is quite steep to get down to this commissure. So we were moving more medial than the first clip and catching the remaining medial flail segments. And to close the medial orifice, we oriented the second clip. So in this A3P3 more A3P3 commissure here, made sure that it was nice and lined up. And then we assessed our MR after the second clip. So we had only mild residual mitral regurgitation at this point, and we had a mean gradient of 4 at 73 beats per minute. So that was a pretty good result. We're satisfied with that. So the next step are future directions. So since Everest, which was in 2011, a lot of things have changed. So we now have the Abbott G5 MitraClip entering the market, which has new sizes. The Pascal Precision System 2nd generation, and also as the clips got better and the interventionalist operators got better, so did mitral valve repair. So we can now offer our patients less invasive mitral valve repair through mini sternotomy. So we're going to discuss trials that are kind of going to address these evidence gaps currently. So despite the fact that there hasn't been a head-to-head since 2011, and there's really no indication right now for lower risk patients to undergo clipping or M-TEER. Increasingly lower risk degenerative primary MR cases are being treated with M-TEER. So since 2019 in the United States, M-TEER has been performed more frequently than mitral valve repair in patients greater than 65 years old with degenerative MR, and not exclusively in patients with prohibitive surgical risks. And a similar trend was seen in Germany with more MitraClips and TEERs being performed for primary MR than mitral valve repair. So the evidence gap is this: there still has been no head-to-head randomized control trial for mitral valve surgery versus M-TEER in primary MR that includes modern devices, modern minimally invasive mitral valve repair techniques, and lower risk patients. But luckily, there are actually 3 randomized controlled trials currently underway. So there is one occurring in France, so the MITRA HR trial, which is a non-inferiority trial, which is going to look at high-risk patients with primary MR, going to randomize some MitraClip versus surgery. and look for a composite of 1-year death, cardiovascular rehospitalization, and mitral valve reintervention. There's going to be repair MR that's going to be sponsored by Abbott, which is going to be a non-inferiority trial that's going to look at moderate risk patients with primary MR and is going to trial MitraClip versus surgery for a composite of 2-year death, stroke, heart failure hospitalization, or need for renal replacement therapy, and 2-year freedom from MR greater than 2+ without reinterventions. And there's also the primary RCT, which is going to be funded by the NIH, and it's going to be a superiority trial for M-TEER. It's going to be all comers. So not just low risk, just moderate risk, not just high risk. It's going to be all comers, like the original Everest trial was, in patients older than 60 with primary MR. And it's going to look at TEER versus surgery, 3- and 6-year death, mitral valve intervention, heart failure hospitalization, and MR greater than 1+. And it's going to look at freedom from stroke and major bleeding. So this will include those lower risk patients, given that we've seen much better outcomes in MitraClip patients in terms of anatomical feasibility and procedural success since the Everest trial, because the clips have gotten better and the operators have gotten better as well. So it's going to be really interesting to see how this is going to play out, given that mitral valve surgery has gotten better and clips operators have also gotten better at treating mitral regurgitation. There are also future directions for patients with primary MR who are not candidate for M-TEER or mitral valve surgery. So there is the Apollo trial, which is investigating the use of the Medtronic Intrepid transcatheter mitral valve replacement system, so TMVR, for moderate to severe mitral regurgitation in patients not candidate for M-TEER or mitral valve repair. So that's going to allow more complex anatomies to be addressed by really inserting a valve into the diseased mitral valve. And there's also, as mentioned, the option of minimally invasive mitral valve repair, which has greater than 95% success rate with less than 1% mortality in experienced centers, such as the Ottawa Heart Institute, with shorter hospitalization time, lower risk of infection, and less blood loss in those patients. So the take-home message is, for now, we don't have the data to support using M-TEER in patients that are not prohibitive surgical risk. So the first question is, do you have severe MR? Is the patient symptomatic? After that, you have to make sure that you have a life expectancy and good rehabilitation potential. After that, you should have the patient always evaluated by a cardiac surgery team to make sure that there is no durable mitral valve repair or replacement option, because as we've shown, the results were better at the time of the trial. And then finally, our role as cardiologists or echocardiographers is to assess valve suitability, as discussed with the criteria, with the techniques that we've discussed. So as a parting message, the landscape of primary mitral regurgitation is changing. The frontiers of treatment for both low risk and high risk patients are being pushed, and that we're going to be able to see with new studies. For now, MitraClip should be reserved for symptomatic and anatomically suitable patients with prohibitive surgical risk, because as we've seen, the mitral regurgitation in primary cases was handled more definitively by mitral valve surgery. But there is increasingly good procedural success in complex cases in high volume centers with expertise. And procedural success depends on rigorous patient clinical evaluation, including a heart team approach and detailed echographic assessment, as discussed. So that's all for me. Thank you for your attention.
In your center, do you have like a tripartite meeting with the surgeons, with the interventionalists?
Yeah. Yeah. So every Wednesday morning, so it's a presentation of the clinical portrait of the patient. The cardiac surgeons are there, the interventional cardiologists are there, and our interventional cardiographers are actually really fantastic at imaging as well. Like, they use a lot of CT and fusion imaging, so they really understand our imaging as well, and us as echocardiographers. So then we discuss. So between the surgeon, between the interventionalist, between the echocardiographers, what we think the best outcome for the patient would be based on clinical echographic CT factors. every Wednesday. Yes. Mm-hmm. I think they can still undergo repair, but it's more complex. But I would have to like just to confirm, like check with a cardiac surgeon. It's definitely more complicated. Maybe someone else in the room might know, but I think it still can be done. Yeah, 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 yeah. Yeah, for sure. And the reason I don't have that much experience in my center is that they really don't do that. Like if the patient is on the table for a mitral clip, it's because like surgery wasn't an option. So usually, when they even if they end up with a like non-ideal result, like at 86 years old, it was kind of that or nothing, which is where the guidelines are at right now. So I haven't encountered that many cases where we decided, okay, that unless there was a single leaflet detachment or like a leaflet perforation where we had to, and even at that, I didn't see that in my fellowship because the operators didn't encounter that. So the patients that we had that had suboptimal results were not referred for surgery because they were high prohibitive surgical risk. Mm,
McGill or handling the situation, you've got a very minimal valve for clip. It's like a 50-year-old person or 60-year-old person. And Marino was looking at it, so how this landed on, I get a great result with the clip, and the patient wants to have it done. Do you, like, are they doing cases like that, or are you just being shunned into to surgery?
Yeah, I think they're being sent to surgery. I think it's an interesting discussion. I think the patient is king or queen of their destiny. And if, they really want that and they really understand the risks of repair and like cognizant of all facts, that's what they want. I think it would be acceptable as a shared care decision, but it would have to be very clear that this is not the most suitable procedure for a young patient with low prohibitive risk, and that there is a risk of reintervention, that we don't even know the durability neither. They haven't been studied for that long. So, if the patient understands all that and still wants a clip, I think it's reasonable to discuss it with them because they're allowed to choose, but it would have to be like really like clear that that was not the first option.
As you know, Ian, every Wednesday morning, we also have our heart team. We just finished ours.
Okay.
It's interesting. We will, like Vince was that we could actually had an 86-year-old lady just speak to that. And Vince says, why don't you try the clip? She's got a lot of anatomical features that make it difficult.
Mhm.
And if we don't get a good result, he's willing to see her and bail us out in the
Yeah.
replacement. But to answer your question, Ian, the 50-year-old we don't even look at. I mean, Vince
Yeah.
is an amazing repair surgeon. Before him was Thierry. So, I don't even think I've never encountered that in 15 years I've been doing it. They just don't even come to us and stuff like that. They'd have to have some type of medically complicated condition to be considered for clip. Yeah.
Yeah.
Because
That's a
sometimes
good
it's
point.
hard, you could say the patient's king or queen of their destiny. I get that, but they don't have the detailed medical knowledge. If you're 50 years old and you're having an Alfieri stitch for Barlow's disease or, P2 prolapse, I don't
Yeah,
know.
no,
I
it's
mean,
not
I
gonna.
can't get my head around it. It's
Yeah.
hard to offer that as a medical therapy
Yeah.
that you think is good for the patient. So that's where I come.
Yeah, for sure. It wouldn't like, would be very clear that this is not what we would like. It would have to be as you, like, you're right. It would have to be like a surgical refusal. Like they would say, we don't, I refuse to undergo surgery. And maybe I expressed myself poorly, but you're right. I don't think it's a durable option for a 50-year-old patient.
Just one general comment. A prerequisite of that is that you have good interventional cardiologist and that you have good surgeon. In the Canadian ecosystem, it might be true. But if you look, for example, in the US, when some centers are doing only 100 cardiac surgery a year, it might be a different problem. And
Yeah.
I think what you want to achieve is good results and good long-term results. How you do that?
Thanks, Paul.
Thank you so much. Huh? I wanted to show my pictures.
Yes.
You're gonna ask me your hard questions then?